Okay, we're going to talk about hypoglycemia. And we're going to talk about it in the first case as a disease in itself, as a presenting symptom. Give me a slide, please. So the definition of hypoglycemia, and I use this a lot, and it's very, very important because for years I've had patients come to me that say, oh, my blood sugar's low, and I eat and it doesn't get better, and I have to call my mom, and she comes over and watches the kids, and I take a nap, and then 6 hours later I'm still feeling bad. And that's not low blood sugar. Low blood sugar is defined very specifically by Whipple's triad. Whipple was at the University of Rochester. In Rochester, New York, is one of the greats of the early last century. I trained there. He had this little museum there that was sort of neat with old stuff that looked fairly barbaric now. But he defined low blood sugar as a blood sugar less than 50 with appropriate symptoms. Now, the appropriate symptoms are these: neuroglycopenic symptoms, which are confusion, anxiety, possible coma, seizure, and adrenergic symptoms, which those are produced by epinephrine and norepinephrine, as in tachycardia, sweats, piloerection, generalized sense of doom, tremor, and then complete relief of symptoms within 10 minutes with 30 grams of glucose. So please keep that in mind. When patients come to you saying, I think I have low blood sugar, the big mistake that was made historically, we would tell people, oh, it may be reactive hypoglycemia, eat 6 meals a day. Lo and behold, they would eat 6 full meals a day. They wouldn't reduce calories. They would then become obese, and they would develop diabetes. In terms of reactive hypoglycemia, the only place I ever see postprandial hypoglycemia is in patients that had gastric surgery or who are pre-diabetic. And I send them all to dietitians to adjust their diet first. Slide, please. Now, this is data in terms of the counter-regulatory hormones. And when we talk about the counter-regulatory hormones, on the top you see blood sugar goes down, free fatty acids go up, and it goes up more in females because they're more reactive. Insulin levels plummet appropriately once you get down below 60, and then glucagon levels are to go up. Now, the response with women are higher than with men. Next slide. And this is, I show this slide for a reason, because a lot of people get sent to me for blood sugars in the 60s or even in the 50s. This study was done in 1973 at the University of Florida, probably on medical students. And they took thin, healthy people, early 20s, and fasted them for 3 days. So they had no caloric intake for 72 hours. And it was fascinating. If you look at the number, normal males, and this is, I don't know if we can I point at it? Well, here's the issue. The mean lowest concentration, which is the middle column, of glucose, yes, there. Can I use that arrow? Or do you have to do it, Catherine? Whatever. Yeah. Men got down to 66 at the end of the fast, but women got down to 47. Similarly, with light males, based on weight, it was even lower at 65 and 47. And they were completely asymptomatic. If you look at females, pre-ovulatory and post-ovulatory, 51 and 47. And then untreated males got down to 71, and women treated with estrogens got down to 68. Now, the whole point of this is to say these people were asymptomatic. They had sugars as low as 47. One woman got down, I think, next slide, please. Yeah, if you, either way, these are fine. Pre-ovulatory, this woman on the left at the bottom got as low as 42. Post-ovulatory, one woman went down to 42 and stayed there for 2 days. And her blood sugars, and she was asymptomatic. So we have to keep this in mind that it can drop low, and we may over-refer based on this slide. And then this is the difference between male and females. The question is, why does females get lower? Well, they have less glycogen stores. They have less muscle or lighter muscle, and they have smaller livers. Men have larger muscle mass, bigger livers, they can store more glycogen, and they're less likely to deplete. But you see with the women, some get as low as 40 and stay there. Slide. So the symptoms we talk about are adrenergic. These are caused by norepinephrine and epinephrine, tremor, palpitation, sweating, anxiety. Neuroglycopenic symptoms, confusion, automaton behavior. Patients, you'll see it once in a while, type 1 diabetics who get low blood sugars at night that they're unaware of. They'll sleepwalk, or they'll be very, very active sleepers, kickers and the like, and that needs to be made aware because it may be low sugar. They could have seizures, and they can have coma, and they can result in death if it's untreated. Slide. Now, these are the causes of it. But generally, when I talk about this, you know, there are well people and there are unwell people. People in the hospital are a difficult group to assess. Outpatients, though, I generally tell people to think about it's either being driven by insulin or not. And we have to remember that our patients aren't always true to us. Alcohol and insulin combination, very bad. I've had 2 young men who I've seen in their mid-30s who were in diapers and tube fed because they got drunked up in college and everybody had fun and all their buddies fell on the floor and they did too, but in the morning the buddies woke up with headaches. These 2 guys didn't. And so alcohol blocks the effects of glucagon. And I will tell my young diabetics, because I'm in a college town, do not use alcohol to get high. I don't substitute what they should take. Insulinomas are rare, but when you get a low sugar that's unprovoked in a non-diabetic, I get an insulin level, a C-peptide level, and a sulfonylurea level. I also get cortisol, ACTH, and growth hormone. Because by doing those 6 tests, I can tell someone as if they had diabetes, or if they're taking insulin, or taking sulfonylureas, or that they have an insulin-secreting tumor, or that they have pituitary or adrenal disease. Now, there are other conditions that are more easily diagnosed, and certainly illness with, inundation, which is, severe replacement of liver stores with cancer, and people just cannot keep their sugars up. Things such as that, inappropriate use of certain medications, suppression of adrenals, liver disease, renal failure, anorexia, starvation. But starvation has to be real. This is serious starvation. So this is a large list, but to remember, the most important thing is that if you have a patient who has hypoglycemia, get the right tests. Get the 6 tests. Slide. To rule these things out, okay? Some are insulin mediated, and this is going to sound odd, but it happened to me once in my career. With factitious insulin use or sulfonylurea abuse or use, one has to think about suicide and homicide. And I had an old man who I am convinced to this day was murdered with glyburide 20 years ago. I took it to the district attorney, he wouldn't touch it. But good workup, because if you do not make the diagnosis when they present with hypoglycemia, then we have to put them in a hospital and fast them for 72 hours. And they're miserable. And so am I when I have to see them. They're really unhappy. Okay, slide. Non-insulin mediated cases, basically we've covered many of them: hypopituitarism, hypoadrenalism, liver failure, severe hyperthyroidism, renal failures, and extremely large tumors. Tumors that have replaced the liver with metastases, retroperitoneal sarcomas actually can ingest more sugar than the body can make. But those are fairly, unfortunately, easy diagnosis to make. Slide. So what do? I do a glucose level, an insulin level, C-peptide level, and a proinsulin level. I do a sulfonylurea level, cortisol, ACTH, growth hormone, thyroid functions, liver functions, renal function. I ask what other medications they're using, what kind of supplements, and do they drink alcohol heavily? Slide. The reason, by the way, alcohol is a problem, and I don't know if I have this in here or not, but I'll tell you, is alcohol blocks the ability of glucagon to branch glycogen. So the glucagon's produced, but it doesn't work. It won't raise the sugar because the alcohol suppresses the debranching enzyme in the liver. So that's why we need to avoid this. Insulinoma is fairly rare. We see one every couple of years up here. They need a 72-hour fast, finger stick every 4 hours or so. Glucose less than 50, we then draw blood for insulin, proinsulin, C-peptide, sulfonylurea. And if at the end of 72 hours they do not drop below 50, we give them glucagon and we measure how much glucose they put out in their beta-hydroxybutyrate. The point being is if they are starved and they are depleted of glycogen because of the 72 hours, they will make no glucose in the 20 minutes after the glucagon. If they have retained glycogen stores, they will make some glucose or release some. That group is a small group, about 1% of the patients. They may need further imaging for insulinomas because they are still making and retaining glycogen. Slide. And this is the fast, the graphs you get of where insulin levels are with glucose and what's normal and what's not. Slide. And then this is the change in the plasma glucose after after giving glucagon. Thank you. Slide. So these are the considerations, and there's where we lay them all out. And so, of the 6 tests you get, insulinoma will have an elevated insulin C-peptide and negative sulfonylurea. Remember, sulfonylureas will have elevated insulin level C-peptide, but a positive sulfonylurea. And factitious insulin will just have an elevated insulin level, no C-peptide, and no sulfonylureas. Slide. Hypoglycemia then into secondary status in type 1s. Now, I tell all my patients I tell all my students that if you have a type 1 diabetic and you're prescribing insulin, you need to prescribe glucagon also. You need to teach a significant other, roommate, parent, how to use it. And you need to refill it about every 18 months. They can be really expensive, but I have one of my really good patients I followed for years, type 1 diabetic, has a seizure on the floor, sugar's low, wife goes to get the glucagon. It's 10 years old, the seal's broken, the powder's gone, and he's on the floor. And so you have to remind people, check the out date on this because they do go out of date. They hate it because so often they have to pay for it. In type 2 diabetics, hypoglycemia is less common than in type 1s, but our monitoring devices are really helping this. If you have a patient, though, who's done really well, that you've had them controlled and their A1Cs have been just steady, 6.5, 7, 7.5, whatever, but steady. And all of a sudden, they start getting low out of the blue because people never change. We try to get them to change diets. We try to get them to change this, and they generally don't. It's old dogs and new tricks. But if a patient who's been controlled starts getting low, think about their kidneys. Insulin is excreted from the kidneys. If they're developing secondary or renal and chronic kidney disease, the insulin will hang around way longer, and they get bigger bangs out of their butt. And so when you see someone who's done everything right, you're doing it along, and all of a sudden they start dropping out, get a creatinine clearance or get a creatinine to see where they are. Now, secondary diabetes. We don't think about it very much, except I see a lot of folks who have what's called secondary diabetes. Pancreatitis is the classic. Who gets pancreatitis? Alcoholics. Do they eat well? No. Do they continue to drink? Yes. So I'm giving them a lethal medication called insulin to patients who are often non-compliant. And the problem with secondary diabetes is they don't only have loss of the beta cell, they have loss of the alpha cell. So they have no glucagon. So I'm equipping them with a lethal syringe that they're defenseless against. And I am very, very careful with them. I talk to them till I'm blue in the face about alcohol and monitoring because they can really hurt themselves. Okay, now when we talk about hypoglycemia in terms of diabetics, the assessment is where did it happen, how did it happen. You know, I have a guy I saw today who's been, I probably followed him for 25 years. He got a Dexcom, loves it, just loves it. He's on a pump, loves it. But he doesn't know when he's going to go work hard. And so he's on this pump and he goes out and works real hard and he gets low and he can't get back up because he's just keeps working. And so we have to make arrangements in certain settings and saying, can you sort of predict when you're going to do this? And if you are, then we set up a dietary plan, you know, Glucerna bar or granola bar before you go out, one halfway through, one after lunch, and with the idea of keeping the blood sugar up and letting his pump control things. The renal function thing I've already told you. Treatment of hypoglycemia acutely is glucose. Okay, many patients want to get glucose tabs. They taste terrible and they're expensive. I tell people to get packets of sugar from Shoney's. They're real cheap and they work more well, and you can just rub it under their lip, and a spouse could do it if they're out. And that's really what they need. And then once you wake them up with free sugar, make sure you feed them complex carbs and continue to monitor their sugar every half hour for 2 to 3. And I think that may be all I have. Next, is there another slide? No, that's all I have. Does anyone have any questions, or did I confuse you more or help?
Guys, remember that you're all on mute right now, so unmute yourself for your questions.
Question.
I think Dr. Pollywall has a question. He's just waiting for a call to stop.
Hi, Dr. Jackson. You mentioned about those workup for the when the patient is complaining of having low hypoglycemia episode. Okay. Now, the way I understand that you're talking about this workup in the hospital, right?
Yes.
Okay. How about
hospital?
Yeah, how about outpatient basis when we do not have any suspicion of like factitious hypoglycemia, but they say that their blood sugar run low and it's 50s. When do we do those tests?
Well, what I do with those folks is I ask them if they can fast from lunch, say today, not to eat, take any calories from today until tomorrow morning, then come into my office and get sugar, glucose drawn, insulin level, C-peptide, and sulfonylurea. The only thing I'm going to say is I know you have to suspect everybody of taking insulin or sulfonylureas. And I know that sounds very jaded, but every person I've ever seen who takes stuff and factitiously, they have issues that they want to be sick. And so my view is I don't trust any of them. I do all the right tests, but I try to get maybe an 18-hour fast and see what happens. And then if you do labs in your office or you send them to the hospital, have them done, you see what they do. But if they're persistently low, you then need to send them up here, I guess, so we got to admit them.
Okay.
Great. Were there any other questions today? Thank you, Dr. Polywall. All right, guys. Well, then we're good to call it. Is there anything else anybody wants to bring up before we end the session? Nope. All right, our next session is on the 22nd. I'll send out a reminder about that again. And that's about, I don't really have any announcements right now. So everybody have a wonderful day.
Thank you very much.
Thank you. Yes, thank you, Dr. Jackson, for that presentation.